Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on mentors and motivators who are consistently reshaping, redefining, and rediscovering the field of medical healthcare. We are thrilled to welcome veteran medical educator Dr. Joel Heidelbaugh, an authority in family medicine, men's health, and mentor to medical students at the University of Michigan Medical School. Welcome, Dr. Joel Heidelbaugh. Thank you so much for your time today.
Thank you. Thanks for inviting us here.
So let's go back to when you were young little Joel.
Okay.
Did you? Only a few years ago. So did you always have an interest in going into medicine?
I think I did. I think thinking about maybe being a baseball player or a musician or a variety of other things, I think that was always central to what I wanted to do. I remember getting science books and being fascinated with the human body and memorizing things and wondering how things worked. And I still find that fascinating. We have a long way to go to understanding medicine in the human body, but I've always found that fascinating, and I think that's what I always focused on in school.
So you majored in what in college?
I majored in biology.
Okay, and you went on to medical school where?
I went to Upstate Medical University in Syracuse.
Okay, and you wound up in Ann Arbor?
I did med school and residency in Syracuse, and then I wanted to practice full-scope family medicine. I wanted to teach. I wanted to do inpatient medicine, outpatient medicine. I wanted to deliver babies. I wanted to do outpatient procedures. I wanted to do research, basically the full gamut of what I could do in primary care. And really, at that point, didn't have any ties to upstate New York and spun the wheel and fortunately landed in Ann Arbor. And I've been there. Go Blue, that's right. And I've been there since 1999.
Okay. So what was your primary inspiration for going into family medicine?
It was the relationships with patients, and it was the ability to know people over time and take care of the family unit and know people over the life cycle, really to develop great skills as a diagnostician, be able to diagnose and treat a very wide variety of conditions, but also within that, not every doctor knows everything within their field.
Really?
Believe it or not, no, we don't. And it would allow me to concentrate in certain areas over time. And so, you know, in my unique practice, while I still practice full-scope family medicine, I have a lot of male patients, and I'm actually one of the few male providers in my practice. So a lot of the men gravitate toward me, and I think over time I took more of an interest in not only preventative men's health, but hormones and cancer screening.
Men are just complicated.
Men are complicated. Everybody's complicated, but
right.
men can be complicated too.
So what are some of the issues that you typically see with the men primarily? That you've geared some of your practice and some of your research and interests into focusing in that area? Sure.
I do a lot of prevention. So obviously I'm talking to men about wellness and healthy lifestyles and how to prevent disease.
So give me some examples.
How to eat better, how to start exercising, how to develop an appropriate exercise regimen, how to sleep well, how to minimize stress, how to work less. That's important. I mean, it's not always easy, but how to create balance in their life. And not only that, but working around age-appropriate provisions of health. So in other words, I would do things differently for a 20-year-old compared to a 50-year-old compared to an 80-year-old. There's different cancer screenings, there's different comorbidities, there's different diseases and disorders that they're going to have throughout the life cycle.
So I'm married to a man, I have a son, and I know that I typically have to repeat things at least 3 times for them to get to listen to, for them to hear maybe 50% of what I'm saying. So how many times do you have to repeat, instructions or what have you to get them to be Say
that again?
Exactly.
Yeah.
Okay. I rest my case.
No, I got it. I don't know. Everyone's different. As a clinician, I think we have to put things at a certain level that people can understand them. I do a lot in medical education, and so I'm sort of famous, or I guess infamous or notorious for always saying to my students and my learners, a patient has to meet you, they have to like you, they have to understand you, they have to trust you, they have to be able to walk out, they have to remember what you've said, and they have to be able to implement things and change their lives. And so if you haven't done that as a clinician and as a healthcare provider, it takes pause for us to be able to go back and try to get things at a level they can understand.
So what are some of the challenges in delivering appropriate preventative health care to men?
Step one is getting men into the doctor. I think the Affordable Care Act did a great job of getting people access to health care. In a lot of ways that opened the floodgates for a lot of men who, one, may not have doctors, or two, may not go to the doctor on a regular basis anyway. So we always say a man is a captive audience once he's in the doctor's office. If he's not there...
Do you lock the door behind them?
I don't, but their wife does when they come with them, or their significant other does, right. or their daughter, or whoever they bring to the appointment, if anybody. So the captive audience is important, and I think once they're there and they see that it's a welcoming environment, they can ask questions about their own health, and you establish that kind of relationship, and you're able to see them back over time, they become more comfortable, and they start asking more questions about their health.
So you deal with a lot of male issues specifically. I know that you recently co-authored the newest guidelines for the diagnosis of erectile dysfunction. Is that correct?
Right.
Can you elaborate a little bit on that?
So this was a fortunate thing as a primary care provider. I'm one of, I think, about a dozen or so folks who are on the American Urological Association guideline for male sexual dysfunction and erectile dysfunction. And as a primary care provider, obviously being at the table with the urologists and the behavioral health specialists was a privilege to do that. This is a very comprehensive guideline that came out in the Journal of Urology a few months ago and walks us through everything from how we diagnose it to how we treat it, and what all the options are, and certainly what's appropriate. I think certainly it's an important topic, but I think what a lot of people don't understand is the relationship between male sexual dysfunction and potentially underlying cardiovascular disorders.
So your participation in this was based on research or patient base or what have you?
Probably my primary care perspective.
Okay.
I still think many men are going to come into a primary care provider first and get referred to a urologist for a variety of issues like sexual dysfunction. And so the importance of having a primary care voice and opinion on that guideline is certainly meritorious, not only for that guideline, but for primary care and family medicine in general.
So switching gears slightly, more than slightly, different body parts. One of your other primary clinical interests, I understand, is gastro-reflux disease, otherwise known as GERD, and other disorders of the gastrointestinal system. So how did you originally become interested in this? And specifically, what are some of the findings that you've found to be particularly significant?
Sure. So my interest in gastroesophageal reflux disease goes back a few decades ago when I had it, and I had it horribly.
The food in Syracuse, huh?
Maybe it was the food in Syracuse. Well, it's probably the great barbecue that we had in Syracuse. But no, I had it. I had horrible reflux, and it was probably a combination of not minding what I was eating and bad hours as a resident and stress and all of the above. And so I learned a lot about it, and this was also at a time in the late 90s when there was a lot of new medications coming out for reflux disease. And so when I came to University of Michigan, they started their own, let's say, internal guideline system, if you will. And that was centered around about 20 or 25 disorders common in outpatient medicine. Reflux disease was one of them, and I was asked to be on the guideline panel for that. And that really took a very in-depth, evidence-based look at the literature at the time to be able to create a statement or guideline principles around reflux disease that practitioners could use. I learned a lot from it, and then a few years later I got interested in why so many people were taking reflux medications and why so many people who got admitted to the hospital were automatically put on them and left on them. And what we found over time was those medications are not necessarily benign for a lot of people, and they may cause some risk. And obviously, you shouldn't take medicines you don't need.
So what are some of the integrative approaches that you would use for somebody who is diagnosed with GERD?
Food and diet, obviously, taking a very strict look at your diet, what you eat, how you eat, when you eat, how much you eat, dare I say all the basics. But I think that's very important. The importance of the nutrition and what we eat and how much we eat and what time of day we eat it cannot be overstated. Our society feeds itself on eating a lot of food and eating late at night and eating high-fat, high-caloric meals, and that contributes to a lot of it. In terms of advice, I think from an integrative standpoint, I think the less medication you can take, the better. I'm probably going to get a lot of criticism for making a statement like that, but I think the less medication we take, probably the better. So through diet, nutrition, appropriate sleep, wellness, minimizing stress, obviously there's going to be people who benefit from those medications. Obviously there's going to be people who can't live without them. Obviously there's going to be people who need them to do well and carry out their day.
So do you practice what you preach? What integrative approaches might you include in your own personal life that make it easier for you to encourage your patients to follow the same route?
I try. I'm not perfect. I did walk by Dunkin' Donuts in the mall today and I didn't go buy anything. So I try to be good. What do I do? I think the basics for me are not necessarily caloric restriction, but I know how much I need to eat and I know how much I shouldn't eat. So I think it starts with the basics. I don't eat a lot of junk food. I'm married to a phenomenal cook, so it's very hard to not indulge, especially around the holidays. But I limit a lot of sweets, I limit a lot of carbs. I don't drink soda. I limit dairy. I eat a lot of lean meats. I eat a lot of fruits and vegetables. I do yoga when I can. I really work out 3 times a week. I spend a lot of time stretching, but I have a bad back and I always have tight hamstrings, so I have to stretch. And then I'm big on mindfulness. And so I have to have a period of time during the day where it's just me time. I have to go somewhere. I have to shut the motor down. I love music. I love to play music. So for me, that is my wellness. So do I practice what I preach? I try to. Do I try to impart that on my patients? Definitely. And that includes diet, exercise, but also the mindfulness on whatever level that they can get that on. Absolutely.
So it seems like every week there's another book coming out, another news story, whatever it is.
I know I need to do another book.
Yeah. I wasn't referring to yours, but yes, you do. But there's so many diets and there's so many, there's so much information out there or misinformation out there. Gluten good, gluten bad. Is, dairy good, dairy bad. Coffee good, coffee bad. Right. So what golden nugget can you provide for our viewers or listeners that if they had to follow one particular diet or eliminate one particular food from their daily intake, what would you recommend?
Boy, that's a tough question. I am going to make a disclaimer. I'm not a board certified nutritionist dietitian, but as a primary care provider, I'm on the hook and I'm obligated every day to give people diet advice relative to their diabetes or whatever the comorbid conditions are that they have. I think step one is you got to know your body. So you and I don't have the same metabolism. You and I don't have the same food tolerances. You and I don't have the same nutritional needs. You and I don't have the same nutritional deficiencies. You have to know what you like. You have to do things in moderation. It's very rare that I would say don't ever eat a particular type of food. I think we really should read labels. Both of my daughters have pretty severe food allergies. So over the years, most of my nutrition knowledge came when they developed their food allergies. I started really reading labels. I avoid a lot of things that have preservatives and all the things that we can't pronounce. I avoid prepackaged foods whenever I can. I avoid things that have, like I said, a lot of the preservatives that you can't pronounce, I think is a good rule. But in terms of saying, I would never eat one particular fill-in-the-blank food, I think that's challenging. I think you have to know what you feel good with after you eat. I think you have to know if you eat something and you feel horrible, then you and your provider should try to figure out why that is.
So there's, especially here at A4M, there are probably, half a dozen companies that are utilizing technologies to better determine what sensitivities one has and whatnot. So do you utilize any of those particular modalities in your practice?
We do. We do a variety of different testing for food sensitivities. We do a variety of different testing for food allergies, and both of those words, sensitivity and allergy, are really defined a lot of different ways. This is a new frontier. I mean, I wasn't taught this in medical school. I wasn't taught this in residency. Things are evolving very, very quickly, and I think it's exciting to learn that we're going to develop this technology to be able to understand what foods and nutrients work best for us and which ones don't, and then we can learn to avoid them.
Also, in terms of some of the new technologies that are out there for every layperson, whether it's the fitness apps or what have you, different devices that monitor various parts of our biometric system. Do you think that this is helpful, and do you add this to their medical records, any of the information and data that they collect personally?
I do. I think the technology is exciting. I learn every day from it. I think any of that engages the patient. And when they don't know about it or when they don't utilize it and you show them an app where they can track their calories or track their carbohydrates or track their steps, track their exercise, I think that's the first point of engagement for a lot of people. People think it's fun. There's great literature that shows that when people are engaged, their health outcomes are better. And the more these apps become more sophisticated and can fine-tune things relative to an individual, I think the better.
So you are a creator, editor, and co-author of the only evidence-based textbook on men's health. Congratulations.
Thanks.
So it's entitled Clinical Men's Health, Evidence and Practice, but
Right.
You already knew that. So how was this idea initially conceived and implemented?
Oh, I got manic one weekend, and I came up with this idea that I was taking a look at my practice, and I saw a lot of men in my practice across a huge spectrum, and I didn't understand it. I'd been out of residency about 5 years, and I would see low-income, low-sophisticated male patients. I'd see high-income, high-sophisticated male patients. I'd see everybody else in between. I'd see people with a lot of different concerns, and I don't think at the time there was any one way to teach people how to take care of these men in their practices, and I don't think there was a way to really make sense of it. And so I came up with this idea to do a book one weekend. I got, like I said, manic. I thought I'd do a textbook, and I figured I'd probably do it in a couple weeks and be done with it. I grossly underestimated that one, but it was a great exercise because at the time there wasn't anything like that. And this was a comprehensive book that took a look at social determinants of men, masculinity factors, why men get their health care, why men don't get their health care, what their viewpoints are on health. And then it took a look at a very comprehensive approach from cardiovascular disease and urological diseases to a lot of common issues in men's health. That was the first book, and then about a decade later I decided I would do another one, and I think they've been well received. I think we've been able to build some curricular models around that. One of the things that's often lacking in medical schools and in primary care residency training practices is how to take care of men. And that's not to say that medical students and residents in primary care don't see male patients. That's not the point. Obviously they do. But I think a lot of times we're ill-equipped in not only teaching, but our learners are ill-equipped in learning how to take care of these male patients, be it from urologic diseases or really the social determinants aspects.
Is it because the male patient isn't as forthcoming with information or not as compliant? What do you think the barrier is that makes it more challenging?
I think a lot of it is understanding how men view their healthcare and what their own role in healthcare is. I think a lot of it has to do with how they seek healthcare to begin with, or how they don't seek healthcare. A lot of men are very in tune with their healthcare. A lot of men go for their annual physicals. A lot of men will go to their doctor on a regular basis when they have questions, or contact us through email or the web portals through whatever electronic medical record system exists. I think a lot of men's healthcare is sought after through other people in their lives. Might be their spouse, might be their significant other, might be a family member, what have you, and they might not initiate that. So I think it's a spectrum.
So in addition to your clinical interests, you are actively involved in teaching young
Yes.
medical students. So do you have any specific or wishes or hopes for the next generation, the future doctors of America? And how do you feel that your role guides and prepares medical students for careers in this ever-changing world of healthcare?
Oh, that's a good question. So at the University of Michigan, I'm very fortunate to be playing a role in a massive curriculum redevelopment. And we are, just briefly, changing things such that a lot of scientific basis is taught in the first year. And then the standard clerkships, or what you would call rotations, are taught in the second year. And then we have professional development branches in the third and fourth year. A lot of medical schools are doing similar models. I'm fortunate enough to be in charge of the patients and populations branch. So I'm focusing on the importance of population health science, what all that means relative to a variety of different aspects of healthcare, one of which obviously could be men's health. So what's important for medical education, I think, is to understand the importance of not only patients as individuals, but patients within the healthcare system, and what that means to populations at large, disease systems and disease states at large, and obviously cost containment and access of care and delivery of healthcare.
So I know that University of Michigan has a wonderful integrative medical program, and that our own Dr. Andy Heyman was very involved in.
Yes.
So in your teachings, do you try to bring in some of the integrative methodologies into your instruction to better, educate these young minds?
I do. The term integrative medicine means a lot of things to a lot of different people. I would never consider myself to be an expert in complementary and alternative medicine and herbal therapies and a lot of the newer, let's just say, non-conventional therapies. I do use some of them in my practice. I would certainly never consider myself an expert. But in terms of primary care, I think everything we do is integrated. I can't just take a look at a man who comes in with erectile dysfunction and write him a prescription and say, bye.
Have fun.
You've got to take into account everything from their psychosocial history and what's going on in their lives, to how that impacts their lives, to whether or not there's risk of underlying cardiovascular disease, and hormonal issues, everything else. So I would call all of that integrated.
So your approach, though, with your medical students, are they getting insight into this world of integrative medicine as we know it here at A4M?
Absolutely. I think more and more practitioners are embracing anti-aging medicine. I think more and more practitioners are embracing complementary and alternative options for treatments. The demand is certainly there with our patients. I have more and more men challenging me with questions and asking me about supplements and herbs and nutritional guidelines and advice, and I find it's a great continuing medical education for myself because I'm always learning. We integrate that into all of our teaching with medical students and residents. I learn from them, they learn from us, we learn from our patients. It's a huge field. It's very hard to keep up on all of it, and it's very rapid in advancement.
So I read an article in the Urology Times, and that you penned, along with another speaker who I had the privilege of sitting with, Dr. Miner.
Sure.
So the title was Men's Health, How Urology and Primary Care Can Work Together. So can you describe how the topic men's health is, or should be, an interdisciplinary specialty, and how your work encompasses that?
Great question. Probably my favorite question I love to be asked. So when you say men's health, or when anyone says men's health, I think people get a few different ideas of things. One, I think they think of, okay, I'm taking care of a male patient. That's pretty short-sighted. I've also had backlash from people, and a lot of my colleagues are women, and a lot of my colleagues are women who do predominantly women's health. They see it as antagonistic, and it's certainly not designed to be that. It's not designed to be anything other than taking care of a man who comes in the office and understanding full spectrum, his healthcare needs, his psychosocial needs, his medical needs, all of the above needs. I think the challenge of men's health is it's not a codified specialty. Nobody owns it. It's not owned by primary care, it's not owned by urology, it's not owned by cardiology, it's not owned by psychiatry, it's not owned by sports medicine. We all see male patients, but we all play a different angle. And so what we've done through the American Society of Men's Health is try to build a bridge and an interdisciplinary network where we're learning from each other and teaching from each other and collaborating and doing research to better understand how we provide optimal care for men.
So you see on TV, there's commercials for, erectile dysfunction, and how easy it is to just pick up the phone and call to get this just shipped to your house. Are there risks involved with that?
Great question. A man can now get various types of testosterone and hormone supplementation and let's say boosters and medications for erectile dysfunction and medications to improve sexual function over the phone. It's been available on the internet for years. You can get them from this country, you can get them from other countries. Those things have been around for a long time.
And this is without clinical supervision?
This is without clinical supervision, or I should say it's without direct clinical supervision. I think in a lot of these cases there's somebody somewhere having some knowledge of signing off on some aspect of some of it, not
But
being
no
your,
follow-up.
no follow-up
Right.
and not being your primary care doc, and your primary care doc may not be aware of it. We have to be cautious about that. I always stress to my patients, I want to know what you're taking. If you're taking vitamin C, I want to know that. If you're taking a supplement, I want to know that, because some of these products are not legitimate. Some of them may be. Again, there's a huge market. When a man comes in and shows me a supplement he's taking, I read the ingredients, I do my research on it. It's just too big for us all to keep up on. I think the danger with any over-the-counter, over-the-phone, over-the-internet product is your physician may not know you're taking it. It may interact with other medications. It may have impurities. It may have toxic risk or adverse effect risk. We just don't know. I have to be a bit of a purist working in an academic research institution. I think, I tend to go by evidence-based medicine. I try to follow guidelines. And I think it's important to know about these things. But they're out there, and I think there's only going to be more of them. And getting, like I said before, getting your patient in to talk to you about what they're taking and what their concerns are a valid issue. A lot of men may want to go the telephone route or the internet route because it's discreet and they don't have to come in and talk to their primary care doc about that or talk to their urologist about it.
So how do you hope to inspire the constituents that will be listening to your presentation today? And what one pearl of wisdom do you hope that they leave with?
Oh, I only get one. Okay.
Well, two if you behave.
Two if I'm, okay. This is always a great group to interact with. I find it's very multidisciplinary. The level of questions and curiosity is fascinating. I'm going to be speaking today on the well male exam and cancer preventative strategies. I'm going to be talking about oxidative stress in the aging male, and I have some case presentations on testosterone replacement therapy and prostate cancer screening. So I'm covering the gamut today in a variety of topics on men's health, and I trust that the questions will be great. What's the one take-home point? Really just to raise awareness, and really to raise awareness for the practitioners in the audience when they engage with their male patients, to listen and to ask these questions, because I have a feeling when they get a man as a captive audience, a lot of these questions are going to come up, and hopefully with my lectures they'll have the answers.
Well, thank you for your time today.
Thank you.
I look forward to seeing you the next time, and go blue.
Thank you very much. Monica, when you were a teenager and you were thinking that KISS was the greatest band in the world, which member of KISS did you identify most with?
Joel Heidelbaugh.
It's a wrap. We're done.